Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition for the summer. Our speaker tonight is Dr. Tamara Petrosyan, who is an associate clinical professor at SUNY College of Optometry and NYC Health and Hospitals, the Gotham Health Center in East New York, in the primary care, ocular disease, pediatrics, children with special needs, vision therapy, and head trauma departments. She lectures internationally, has developed over a dozen vision therapy workbooks, has published articles and book chapters on numerous topics. She is the infancy liaison for New Jersey, had the clinical care committees for pediatric and vision therapy, and previously on the board of directors for the New Jersey Society of Optometric Physicians. She has been awarded the Young Optometrist of the Year and Optometrist of the Year from the New Jersey Society of Optometric Physicians and Young Optometrist of the Year from the AOA. I think we're going to have a great, I know we have a great speaker. We're going to have a great topic, great time. We're going to have our Saturday in the park here on a Sunday night. And with that, Tamara, please take over. And we're looking forward to hearing what you have to say.
All right, thank you guys. This is a pleasure, and thank you everyone for joining in on Sunday night. So, as we must, my disclosures, but nothing that we're going to be talking about. Is there any conflict for, or do I have any financial interest in? So, before we start talking about the actual drugs, I like to really understand what the medication is doing. And to understand what the medication is doing, we really need to go back a little bit and talk about the pharmacokinetics and pharmacodynamics and go back to pharmacology class a little bit so that we can really understand what's going on with the medication in our body, what the medication is doing to our body, and then what the body is doing to the medication. So just bear with me a little bit. On the right side, you'll see photos, which hopefully makes this a little bit more interesting for you guys. But when we're talking about oral medications, we talk about our pharmacokinetics and then our dynamics. So the kinetics is the drug's journey through the body. So how do we absorb it? How is it distributed in the body? How is it metabolized? How do we get rid of it? So it's really, what is the body doing to the drug? And then we have the dynamics, which is, how does the body actually respond to the drug? So what's the mechanism of action? So that's, what is the drug actually doing to your body? If we talk about the stages of the pharmacokinetics, liberation, so that's how you take it, and depending on how you take it is going to affect how much of a dosage you get, how it's going to actually affect that tissue, how it's going to circulate through the body, how it's absorbed, then how it gets distributed to the body, and then eventually how it becomes metabolized and leaves the body. The liver, if we think about it, has the largest housing of something called cytochrome P450. So this is a class or a family of enzymes. And what they do is they actually will metabolize all of the drugs that you take orally. The drugs will go through something called a first pass through the liver. So they don't actually go to your target area, or they don't go into your blood right away. They actually go into your liver first. They do that first pass. The enzyme family, cytochrome P450, will metabolize the medication, and then that metabolism is actually going to inactivate the medication more so than when you took it, and then pass it into the blood for it to go on its way. So, the P450 family is mainly going to be found in the liver, but we have it in other places too, like the GI tract, small intestine, the kidneys, but the liver is mainly where it's going to be housed. So when we take medication orally, we're always going to have that first pass. But when we take things through an IV, intramuscular, topical, including our eye drops, anything sublingual, inhalation, it actually doesn't go through that first pass. It goes to the target tissue first, and then eventually it goes to the liver to get metabolized, to get a little bit less active, and then goes on back over into the bloodstream. Prodrugs, which we're not going to be really talking about prodrugs today in terms of the medication, but they're very, very interesting medications. What a prodrug is you will take the medication in its inactive form, and the medication isn't actually active until it goes through the liver and gets metabolized, and only then does the drug get actually activated. The reason we do this is because when you take a prodrug, we're going to get better tissue penetration. We are going to have a much more active metabolite at the receptor site, and then we're also going to get a lot less adverse drug reactions. So if you take a look at these different classes of medications, these are all going to be the prodrug form. So I just find it very interesting that a lot of the medications that we take, even some of our NSAIDs, are going to be our prodrugs, which are inactive, and they only get activated once they go through that first pass in the liver. So, when we are prescribing or considering prescribing oral medications to our patients, there are obviously things to consider, such as what's the correct medication, right? What disease are we treating? Do we know what it is that we're treating, and what's the correct medication for that? But aside from that, we really need to look at the patient as well. We need to take a look at their age, because depending on if they're younger, if they're older, the drug might be contraindicated for them. Their genetics is going to play a big role. And more, we have companies coming out where a patient can do a saliva swab that's sent to their home. It gets sent to the laboratory, and they'll actually give you a genetic panel of which medications will give them a worse adverse drug reaction, or that they're actually allergic to. And so you can try to stay away from those medications. So that's becoming a much higher or key player in our oral world. Their gut microflora, because if they, for example, have very big ulcers that are causing them problems, we might try to shy away from some of the medications. Their renal function and their liver function is going to be key for any medication that you're giving them, as we know, right? Our kidneys are going to help filter out the medication, secrete the medication. Our liver is obviously going to metabolize it. Diet is one that is very important for us to consider, especially with some of the antibiotics we're going to be talking about, but a lot of the other classes of medications as well, because depending on what they're taking the medication with, their diet. So, for example, if they're taking antacids, if they're eating grapefruit in the morning, if they're drinking some milk, that could totally um, prevent the medication from working. It can decrease the efficacy of the medication by up to a half, or it can actually increase the efficacy of the medication, and you're getting a much bigger bang for your buck than you ever intended to, and might get a lot of adverse drug reactions. So, for example, if we talk about some of the medications, such as um, erythromycin, amiodarone, cyclosporin, grapefruit, macrolides, these are things that can block the action of that enzyme group, the CP450s. It's going to block its ability to metabolize the medication. And so, if you take a medication with these things, then it can actually give you more medication in the bloodstream. Versus things like alcohol or barbitals, they will actually induce or make the enzyme much more active and make the metabolism of medications much more active. And so you get a lot less drug in the blood than you actually intended. So those are important things for us just to keep in the back of our mind, not just for our patients, but for ourselves, for our family members. The grapefruit situation, some of us might think, well, who eats grapefruit, or but a lot of people drink grapefruit juice, right? So even if you don't have, so first of all, a lot of people will sit there and actually eat a grapefruit with a spoon, and you don't know until you ask. But second of all, a lot of people drink grapefruit juice. It's a very common thing to drink, and that is going to change the way that our body is going to metabolize these medications. And so that is something to consider talking to your patients about if indicated. And there's a couple of the antibiotics where it is, and that we'll talk about. Um, let's see here. So we talked about the kidneys. We talked about the liver. Just really quickly, because a lot of times people will actually ask about this. So, the things that we're touching upon are things that when I deliver these lectures, they'll always kind of come back and ask these types of questions. So, we're just going to touch on some things that are more commonly asked about. So when we take an oral medication, it's going to be eliminated through our kidneys, right? But it's going to be eliminated in two different ways or two different orders. So we have our zero order elimination. So that means that we are going to eliminate a specific amount of drug over an hour. So every hour, we're going to get rid of 5, 10, 15 milligrams, milliliters of the drug, no matter how much of the drug we have in our system. So Lacrosert is a wonderful example in terms of how it gets released once you inject it into the anterior chamber. So that's going to excrete the medication on a zero order elimination. So you're going to get a specific dosage over an hour constantly, um, no matter how long it's been sitting in there. Alcohol gets excreted at a zero order elimination. So you're going to excrete a specific amount of alcohol every hour. And then we have our first order elimination, and that is going to change depending on how much drug is actually in your system. So most oral drugs are going to follow this type of elimination, and our topical drugs are going to follow this type of elimination. So that means that you are not getting rid of a specific amount of drug every hour, you're getting rid of a specific amount of drug. So for example, you'll get rid of say 5, 10, 15, 20% of however much drug there is over each hour. And then aside from the age and the genetics, the allergies are going to be very important. Some of the medications we're going to be talking about can cause very true allergies, and it can send a patient into anaphylaxis. So allergies you're going to be asking about always before you start a patient on any oral medication. The body weight, especially for our pediatric, but also our geriatric patients, and also our very obese patients. So if someone is very obese or someone is very malnourished and has a very low BMI, as well as if they're very old or very young, the medication is going to work a little bit differently, or you're going to want to adjust the dosages for them. So that's important for us to know. What current medications are they taking? Once we reach 4 medications or more orally that a patient is taking, that's called polypharmacy on our patients. And those medications, even if they normally, so if you take, say, 2 medications, they wouldn't normally interact poorly with each other. Once we start taking 4 or more medications, there's a much higher likelihood of those medications poorly interacting with each other or within the body. So we really want to try to limit the amount of oral medications our patients are taking. And then diseases, especially kidney and liver disease, but autoimmune disease as well. So if you have an autoimmune disease, that can actually change how the body utilizes.
Did you lose sound, Joe?
Yes, I think
Did
she's
we
just
lose sound?
frozen. Yeah, you're frozen for about 10 seconds.
Oh, sorry. Okay, we're good.
Hmm.
Okay. Um, One of the key things that is important to remember, especially with antibiotics, is the allergy component. So a lot of times, your patients might tell you that they have an allergy to an antibiotic, and they might not. They might think they have an allergy, but in actuality, it's just a GI upset because they took the medication without food, and GI upset is a normal side effect of the medication, and they just thought it was an allergy, or they just might be hypersensitive to the medication, but it's not a true anaphylactic allergy. Only about 1 in 10 patients really have a true allergy. So, penicillin, for example, is one of the more common ones where people will say, I have an allergy to penicillin. But while 10% of people will actually say that they have an allergy to penicillin, in actuality, it's only 1% of the population that has a true allergy to penicillin, and the other the other part is just going to be a GI upset. So it's important for you to really question your patients when they say that they have an allergy to an antibiotic, because sometimes that might be the best antibiotic in terms of its efficacy for that specific condition. And sometimes the alternative antibiotics might give you much worse side effects. And so you really want to make sure if it's an allergy or not. Um, let's see. This I just wanted to point out in terms of our allergies to medication specifically, or in general that are reported, is going to be latex for about a quarter of the people, tree nuts and shellfish, especially in the food allergies, for about a quarter of the people. When patients report allergies to medications, oral medications, it's usually going to be penicillin or NSAIDs. Those are the big ones. But again, about 10 to 15% of people will report it, but in actuality, only about 1% of people are actually allergic to it. And then venom, 15%. I found an interesting statistic to bites and stings from insects in terms of the top allergens that we have reported in the population. In terms of body weight, a lot of people will be very hesitant to prescribe orals for the pediatric population, and you do want to be cautious in that population. Definitely, if you're going to be prescribing orals for your pediatric patients, it's a good idea to maybe get the pediatrician on the phone and have a chat with them. But it's a lot of times something that is necessary. So you do your clinical exam, you do your decision making, and if you can use a topical, wonderful. But sometimes, a lot of times, we just need an oral, and that's perfectly fine. The majority of these medications, if used appropriately, are going to be very safe. We just have to make sure that we know what dosage we're prescribing for them, and that I feel is where people get a little bit more cautious or hesitant because they have a difficult time figuring out what dosage to prescribe in terms of orals for the pediatric population. And especially nowadays, it's really not complicated whatsoever. You have a lot of online dosage conversion calculators where you just put in the medication, you put in how many times a day you want the patient to take it, you put in what dosage you want them to be taking it at, and it'll calculate for you exactly how to write out the prescription. The AIs, most of them can do this now as well. If you're ever in doubt, just call your pharmacy and the pharmacist will figure it out for you. They have all of this information. But I just want to quickly run through converting a medication for a pediatric patient, just to show you that it's, while we have all of these tools, sometimes you might not have them on hand, and it's really not as complicated as some people might consider it to be. A couple of notes for doing orals in the pediatric population. So, when we're talking about orals in pediatrics, if the child is 12 years or older, you're going to go with the adult dose. If the child is 100 pounds or 45 kilograms or heavier, you're going to go with the adult dose, because if you go with a lower dose, they're not going to get a therapeutic dose in their system at the target site. And so when we're talking about pediatrics, we're talking about 12 and younger. We're not talking 18 and younger. And if you have a 10-year-old who's, pushing 150 pounds, they're going to be getting the adult dose. Um, when we're doing conversion of orals for pediatrics, first of all, we need to know how much they weigh. Usually, the parents or the kids will know. If not, if you're doing a lot of orals in the pediatric population, not a bad idea to have a scale in your office. But you're going to convert pounds to kilograms. And you're going to do that by taking the pounds and dividing that by 2.2. And then you're going to multiply their weight in kilograms by the recommended dose. And if you go on any of the like the RX scripts or any of the medication hubs, they all have the dose recommendations listed out for you. So that's extremely easy to find if you don't have it in mind. And you are going to, so that's going to give you how much medication they are going to have per day. You're going to divide that by the daily milligram total. and you are going to write out how much medication they are going to get. So let's just quickly go through an example. So you have a child that's 40 pounds and you want to prescribe amoxicillin 20 milligrams per kilogram 3 times a day for this child. So first we're going to get their weight in kilograms. So we're going to convert pounds to kilograms by dividing 40 pounds by 2.2. So that gives us about 18 kilograms. We're going to multiply the weight in kilograms by the recommended dose. So we're going to look up in our RX scripts what the recommended dose is for this specific condition, and it says 20 milligrams per kilogram for the pediatric population. So we're going to multiply our 18 kilograms by 20 milligrams per kilogram, and that's going to give us our total daily dose, so 360 milligrams total for the day. They're going to be taking the medications 3 times a day. So we're going to divide that full daily dose that they're going to get for the whole day into 3 doses because they're taking it 3 times a day. So that's 120 milligrams 3 times a day. And then we are going to look and see that the manufacturers don't make amoxicillin in 120 milligrams. It comes in 125, it comes in 250, it comes in 400, it comes in 500 per 5 milliliters. This is where the pharmacist comes in handy if you don't have the tools to look it up. And we're going to choose the closest concentration to what we actually need. And this is where the clinical decision making kind of comes into play. So if you have a condition, so say if it was our daily dose, our 3 times a day dose was 200 milligrams instead of 120. It's kind of in the middle between 125 and 250. If the condition is really not that bad, you might want to go down to the 125 milligrams. If it's a more aggressive condition and you're dealing with something that you want to hit a little bit harder, then you're going to put it up to the 250 milligrams. So that's where your clinical decision making really comes into play. And then you just write that out of as amoxicillin 125 milligrams per 5 milliliters, and they're going to drink 5 milliliters of the medication, which is going to hold 125 milligrams of the amoxicillin, and they're going to be getting that 3 times a day. So really not as complicated as you might think, but again, a lot of different tools that will allow you to do that without any need for mathematics. The drugs that they are on, again, very important to know how many drugs, what drugs, but anytime we're dealing with warfarin, Coumadin, those are going to be the big ones that we really need to pay attention to, especially with the antibiotics, because then we have an increased risk of either an increase in clotting or decrease in clotting, depending on the medication, which we don't want to mess with. So definitely we'll be working with their hematologist if we need to put them on an oral medication there. And then a lot of these medications should be taken with food, or some of them specifically should be taken on an empty stomach, and we'll go through those. So we talked about, making sure that you know the patient's renal function, their pulmonary function. Some of these medications can give respiratory problems or aggravate a COPD. So we want to know if they have that. A lot of the diabetics will have a contraindication to taking specific medications because it can drive up their sugar. So they shouldn't be taking NSAIDs, for example. So you really want to be careful or cautious with your diabetics, as well as anyone that has any cardiovascular disease. And then we already talked about inflammatory diseases. So if someone has an autoimmune disease or a systemic inflammation going on, these will actually increase the amount of glycoproteins inside of the body, which is then going to decrease the bioavailability or the amount or efficacy of the drug inside of specific medications. So things like opioids, things like antidepressants, tetracyclines, macrolide antibiotics. If you have a patient with an inflammatory systemic disease, the macrolides, tetracyclines, antidepressants, opioids are actually going to have a decrease in their efficacy for these patients. And then it's been 10 years now where they've changed the pregnancy category. Most people will say historically category ABC, or X, but pretty much what changed there, the reason they changed it is they still talk about the effect of the medication on pregnancy, the effect of medication on lactation, the effect of the pregnancy on female reproductive potential. The big thing that they changed with this labeling is they talk about the effect of the medication on male reproductive potential. So if it's going to affect the male population in terms of reproduction is the big thing that changed there. But you'll usually hear people say historically category ABC. If we're dealing with our pregnant patients, so this is not just antibiotics, but with pregnant patients, we always want to be careful. We always want to talk to the OB, get an okay from the OB. But if we need to put our pregnant patients on an antibiotic, we never use fat, so no fluoroquinolones. We usually don't ever use oral fluoroquinolones unless absolutely necessary anyway, because they come with pretty severe black box warnings. No aminoglycosides, no tetracyclines. For our pregnant patients, we want to use PAC. So it's safe to use penicillins, azithromycin, and our cephalosporins in terms of our antibiotics. And then you have some antivirals, the anti-inflammatories, and the analgesics that are safe to use for pregnant patients. In terms of why, so a lot of people will kind of say, well, why can't I use a specific medication or a specific antibiotic on a pregnant patient? And it really messes up the fetus. So you can get nerve damage, you can go get hemolysis, you have issues with bone development, they get metabolism changes, you get limb abnormalities. So you really want to talk to your OB, to the patient's OB, before prescribing orals for your pregnant patients, if you're not sure. In terms of brand name and generics, this is one, both for topicals and for orals, one where people can get into a little bit of it's a discussion point, definitely. But I think it's important. Most people don't really know what the specific difference or what's allowable from a brand name to a generic. And I think it's once we go through this list, if you've never read through it, it'll be an interesting kind of aha in terms of what's actually allowable. So a generic drug can apply to the FDA to be approved as a generic for a brand name if it goes along with these things. So the manufacturer of the generic has to be capable of making the drug correctly and consistently. That's a given. The generic is pharmaceutically equivalent to the brand, but that's a little bit kind of wide or broad in terms of what does that actually mean, pharmaceutically equivalent. The active ingredient has to be the same as the brand name. There has to be the correct amount of the active ingredient that gets to the target tissue. So that's good and that's important. The inactive ingredients have to be safe, but they can be totally different from the inactive ingredients of the brand name. The drug does not break down over time, so it's shelf stable, important. The container of the drug is appropriate for shipping and for sales. The labeling is going to be the same as the brand name drug's label. And then relevant patents, legal exclusions of the brand are expired. So that's the patent information. The thing I find very amusing, let's say, is that there's absolutely no mention of bioavailability, right? So the extent of absorption and the first pass effect, so the metabolism of the medication. So how much of the drug is actually available in the system, in the blood, to get to the target tissue once it goes through first pass, once it goes through the liver. No mention of that whatsoever. So the bioavailability of the generic and the brand name can be totally different between the generic and the brand name drugs. And that is really where we find some of those differences that we see between our brand names and our generics. I've been prescribed oral medications, not frequently, but I have been. My kids definitely. There's four of them, and they get sick very frequently. So them as well. It's interesting how little information you get from the prescribing doctor in terms of how to take the medication, when to take the medication, what to take it with, what side effects there are going to be. They'll mention maybe one or two side effects, but maybe not the third or the fourth, which is very significant and happens frequently. And you're getting the side effect, and then eventually you're sitting there Googling it. So if you're going to be prescribing oral medications or any medication really, um, I would say it really is your responsibility to make sure that the patient knows how to take the medication, when to take the medication, and also what to do if there are any side effects or if they miss a dose. So that's a big one, right? So do I take two doses at the same time? Do I just skip the dose? What do I do if there's a dose missed? It's really our responsibility to make sure that our patients know this information, because then they're going to end up just sitting there and Googling it, and you know that they're going to get the information wrong half the time, if not more than that. Um, so how do they store it? Does it need to be in the fridge? Does it need to be in a dark cabinet, cold, hot? Don't keep it in the car when it's 100 degrees out, because the medication will kind of break down, right? So that's critical information. Any foods or drugs to avoid within an hour or two before or after taking the medication. Um, do I skip if I've missed a dose, do I totally skip it or do I take two doses? The general guideline, the general go-to is we do not tell patients to take two doses of a medication. So if it's only been an hour since they were supposed to take a dose and they're supposed to take it every 4 hours, then go ahead and take your dose. It's okay. But if you're supposed to take your second dose in half an hour and you skipped your first one, you're not going to take your first dose and then in half an hour take your second dose, because we're getting a lot more concentration of the drug in our system than we ever intended to. And then we want to talk to them about the potential side effects as well. All right, so polling question number one, that should be popping up for you guys to answer. We're going to be, I'm not really expecting you guys to get this information correct. I'll be very, very happy if we do. We're going to be talking a lot about mechanism of action. So I just want to see, what is the mechanism of action of macrolide antibiotics, such as azithromycin or Z-Pak? So does it prevent folic acid synthesis? Does it inhibit the synthesis of the cell wall? Does it inhibit synthesis of proteins? Or does it inhibit synthesis of nucleic acids or DNA in the bacteria?
And while those are going on, and when
Mm-hmm.
everybody is going to be voting, question came in: is there any
Yep.
sensitivity tests that can tell if a patient has a true allergy before prescribing a medicine?
Say that. What was the first part? Sorry. Is there
Is there
any
any
what?
sensitivity testing that can tell if a patient has a true allergy before prescribing?
Yes. So you are able to do, if you send them over to an allergist, they have blood testing that can be done that will tell you if they actually will have a true anaphylactic reaction. And then some of the swab tests, the cheek swab tests, will be able to do that for you nowadays as well. And it will tell you both how efficacious the antibiotic is going to be for that person's kind of metabolic and genetic structure, as well as if they are going to be prone to anaphylaxis with that particular medication. So if you have any doubt, send it to an allergist, the patient to an allergist. And also, someone might be allergic to a medication as a child, and you outgrow these allergies actually. So as an adult, someone might outgrow a medication allergy that they were allergic to as a child. And about every decade, your allergic profile to oral medications can actually change. So if you have someone where you really want to put them on a specific oral and they're a little bit hesitant, then you send them to an allergist and they'll do a blood panel for them.
Yeah, in our practice, we have an aesthetic center as well as dermatology.
Mm-hmm.
And if we have patients who are on chronic medications, topical, we can actually send those over for sensitivity testing, and they're pretty
Mm-hmm.
good about it, and they're pretty, tell me they can use brimonidine, but they cannot use latanoprost or
Right.
vimatoprost, but Timwall is fine, so
Yep.
it
Yeah.
can
It
it
can be
can be
very, very
helpful.
helpful, definitely. I don't know. I mean, you probably have more readily access to it than I do, Joe. But I don't seem to have to use. I have sent patients out for sensitivity testing, but I haven't really had to do it too frequently.
Yeah,
I
we've
don't
we've
know.
had we've had we've had a few. I've had
Mm-hmm.
a few people that have the constant allergic dermatitis when they're using
Yeah.
eye drops, and we
Mm,
actually had to bite the bullet and figure out which ones they can use because
mm.
she's a glaucoma patient.
Yeah. I had one. I totally forgot about it. Last 2 weeks ago, I had a patient came in, diabetic, macular degeneration, refusing to get dilated because he's allergic to eye drops. At some point in time, like 15 years ago, he went to the eye doctor, they put some drops in, and he got allergic to them and just refuses to get dilated. So as much as I tried to kind of calm him down, it was a no-go. So we actually ended up sending him for sensitivity testing, and I'm waiting for that to come back.
Yeah,
See how that goes.
ironically, I had a patient recently tell me they're allergic to Benadryl.
That's not a good situation. All right.
So,
So
so,
can we
so, yeah. So your replies are, but that's a great question. I guess in Joe's situation, when it's chronic and it's glaucoma, we can do that. But if you have an infection here, you might, by the time you get all that testing done, it might be a little tough to, the infection might be gone, or if it's
yeah,
a
the
serious
infection will
infection,
resolve.
yeah.
Yeah.
Yeah. Or you might have to, just kind of bite the bullet and go with it. But that was a great question because this pharmacokinetics and pharmacogenetics is really
Yeah.
kind of taken off over and it's going to really help us out going forward. But the answer to your question now, you had 11% going at folic acid synthesis.
Mhm.
Um, we had inhibit cell wall at 39. We had protein synthesis at 41 and DNA synthesis at 9. So,
All right. So let's see how we did. Ooh, where'd we go? So we got the majority, so close to 50% were accurate. Yes. So inhibits protein synthesis. So our macrolides, azithromycin, Z-Pak, those are going to inhibit protein synthesis. So that's kind of it for all of that, the PTSD from pharmacology back in the day. So we're actually going, well, no, I lied. Actually, we're gonna still talk about the mechanism of action of the antibiotics, but this is much more targeted, not as general. So verbiage wise, some people get a little bit confused in terms of antimicrobial, antibiotic. A lot of times they're used interchangeably, but they do have specific definitions. So an antibiotic is something that is actually made by another microorganism, and it is made by that microorganism specifically to suppress the growth of a competing microorganism. So that's your antibiotic. And then we have antimicrobials, right? So that we use very frequently, and those are your laboratory made things that will suppress the growth of a microorganism. So an antimicrobial made in the lab, antibiotic made by another organism. We have our normal bacterial flora, right, both on our skin, in our mouth, in our GI, and that is critical for our health and for our well-being. So if you've been keeping up with, the latest CE, you'll find how important the GI tract is to our general health, our just general well-being. It's becoming a much, much more critical conversation that we're having with our patients. And that relationship between our normal bacterial flora, if it becomes abnormal, that's when we start having problems. That's when we start getting things like infections, because we have release of antigens and toxins that are more so than would have been. We have a change in our normal flora, and then we have eventually a direct invasion of the tissue, or we have inflammation from the bacteria that's not supposed to be there. So our gut bacterium, our normal eye bacterium, gut bacterium, mouth bacterium are all very, very important and critical. And we'll talk about probiotics for our patients that we're putting on oral antibiotics. The cell wall is going to be critical when we talk about how the antibiotics actually go ahead and kill or destabilize the bacteria that we're trying to fight. So when we talk about a gram positive, what that means is on the outside of the bacteria, their wall, they have a peptidoglycan wall. But that wall is going to be very, very thick for a gram-positive bacteria. That's why they get that stain when we stain them. They stain nice and purple, if you remember back to biochem. So those are going to be our staph, and those are going to be our strep that we commonly see on the eye and the adnexa. Our gram negatives are going to have a very, very thin peptidoglycan layer, and they're also going to have an outer lipid membrane. And those are going to be our things like Haemophilus, Pseudomonas, Neisseria. So more so things that we see maybe more so in the pediatric population or contact lens wearers. And chlamydia is a fun one because it's actually a bacteria, but it likes to behave or mimic viruses as opposed to actually function as a bacterium. But when we're talking about the eye and the adnexa specifically, we are going to be dealing much more so with our gram-positive bacteria, the ones that have that really thick peptidoglycan wall encircling the bacterium. So those again are going to be our staph and our strep that are going to naturally just sit on our eye, on the adnexa. Again, talking about that balance that we have. When we have a break in that balance, or we introduce a lot more bacteria by touching something and then rubbing our eye and introducing it to the eye, that's when we start getting this imbalance and getting those infections that we start having to treat. And then we'll talk about MRSA a little bit, but we can eventually, if we're dealing with Staphylococcus aureus, we can end up getting bacteria that is resistant to the medication that we're giving it, and we have to alter the medications that we're using, but we'll talk about that. The Streptococcus pneumonia, that is going to also be a bacterium that we are going to find on the ocular surface, but the kind of more scary part with the strep pneumonia is that it has hyaluronase enzymes that are actually going to get produced and allow the bacteria to physically penetrate into the cornea, penetrate into the tissue, and into the lid, and that's what's going to end up causing the corneal perforations or the orbital cellulitis. So that's where we don't really want to sit on and for example do sensitivity testing. We want to get an antibiotic on that eye so that it doesn't lead to a corneal perforation or an orbital cellulitis. So in terms of, we said that the gram positives are going to be our main ones that are going to be sitting on our eye and causing the majority of our infections. Some people do become interested in what specific bacteria we're dealing with. So with our blepharitis, we're usually dealing with staph, Pseudomonas can come in as well. Our hordeoli is usually staph. If we're dealing with a conjunctivitis or a preseptal, staph, strep, as well as in our kids, we're going to get more Haemophilus. If we're dealing more with the dacryocystitis, then E. coli is actually big up there, Pseudomonas, especially in our contact lens wearers, and then staph and strep. And our endophthalmitis is usually going to be a strep. With the strep, specifically if you have a post-operative where they didn't use proper hygiene, or if you have a trauma, then the strep epidermidis is going to be your most likely culprit there. So, a mix, but we're usually dealing with staph, strep, pseudomonas, Haemophilus, and every once in a while we get an E. coli in there. So that's kind of what we're going to be fighting against. In terms of choosing the antibiotic, we want to try to choose something that is narrow enough that is going to really attack the organism that we're trying to attack, but broad enough so that we don't miss any of the other organisms that might be hanging around there. So when we talk about broad versus narrow spectrum in our antibiotics, broad means that it works against a very large different group of bacteria. Usually we'll be including gram positives and gram negatives. Narrow meaning it works against a specific or a very limited group, so maybe one or two bacterial strains. And if you've cultured a infection, for example, and you send it out, you might get a report back giving you a very specific antibiotic, specific dosage that will be effective for that specific culture, and then you're doing much more of a narrow kind of therapy. So, in terms of considering if we should be doing an oral or a topical for our ocular infections, the majority of the time, our topicals are going to, if we're talking about an infection on the surface of the eyeball itself, our topicals are going to do a much better job than our orals ever will, because the orals are not going to get to the ocular surface anywhere near as quick or as hard as our topicals will. Our orals, we are really going to be considering when we're talking about an infection of the tissue around the eye, the adnexa of the eye. That's really when we start to think about doing oral medications. All right, so let's delve into how the antibiotics actually attack our bacterial cells. So anything that has a red X next to it, that means it's cidal. Cidal means it kills the bacteria. It makes it so the bacteria dies. It's not able to live. It autolyses and kind of blows itself up pretty much. Static, the blue ones, those are going to be where the antibiotic is going to make it so the bacteria can no longer replicate itself. So you're not getting any new bacteria growing or coming into the eye, but it doesn't actually kill the bacteria. So that's when your immune system really has to partner with the antibiotic and kick in and get the bacteria out, because the bacteria that's already kind of replicated and living on the surface or inside of the infected area is still there. We're just not making anything new. And that's you're having a good immune system is really going to come into critical play with any of our static medications. So when we talk about our cytals, and most of our antibiotics that we're going to be talking about are going to be our cytal medications. It's going to be our penicillins, our cephalosporins, quinolones, aminoglycosides. Those are all going to right off kill the bacteria itself. With our sulfonamides, with our tetracyclines, with our macrolides, those are just going to stop the bacteria from reproducing. And so we really need to make sure that the immune system comes into play to take care of whatever bacteria stays inside of the adnexa or on the ocular surface. This is just a graph or a chart, I guess, demonstrating the different classes of antibiotics. So there's quite a lot of different classes of antibiotics, some that honestly I hadn't really heard of before, because they are used in very specific cases. They are IV or intramuscular and used in a very specific situation. But this is just to goes to show you the different options in the antibiotic arsenal, but the ones we are going to be dealing with in the optometric world for our orals are going to be the beta-lactams, the sulfonamides, the tetracyclines, and the macrolides. So let's talk about, let's see, let's talk about the antibiotics that are going to kill off the bacteria by inhibiting cell wall synthesis. So if we think back, right, to cell biology, um, the animal cell does not have a cell wall, right? Only our plants and our bacteria are going to have a cell wall. So if you are targeting, if you're using an antibiotic to target a cell wall to kill the bacteria, it's not going to cause too many side effects for the human because we don't have a cell wall, right? So it's actually a wonderful mechanism of action because it destroys something that the bacteria has that we don't have. So the antibiotics that are going to inhibit cell wall synthesis are going to just work on the bacterium. And those are going to be our beta-lactams, so our penicillins and our cephalosporins. And this is really why those are some of the main go-tos for our antibiotics, no matter what infection you have or where your infection is, because they don't really attack the animal body. The antibiotics that attack the cell membrane, and everyone has a cell membrane. So we have a cell membrane, so do bacteria, so do plants. The ones that attack the cell membrane are going to kill off anything that has a cell membrane. So these antibiotics are going to be very toxic to us as well as to the bacteria. And so we really save these medications for anything where we really have to hit it hard and they're resistant to the other things in terms of oral medications, right? So polymyxin B, you'll see that a lot in the over-the-counters, the over-the-counter ointment. But when we're talking about oral medication, polymyxins and lipopeptides, we really don't do as a go-to for orals because they cause a lot of toxicity to our cells as well. The antibiotics that are going to inhibit nucleic acid synthesis, so our nucleic acids or DNA, RNA, they're going to carry the genetic information, which is then read to make proteins. Is going to be the same for everyone. What is different is the DNA polymerase, which is going to allow us to replicate the DNA, as well as the DNA gyrase, which is going to allow how we, well, they both really work on replication. So the DNA polymerase, DNA gyrase for bacteria and for humans is going to be different between the bacteria and animals. So this is another one of those mechanisms of action where it will attack the bacteria, but not attack the animal or the human DNA, RNA, and those are going to be our fluoroquinolones. Unfortunately, while it's a great antibiotic to kill off the bacteria, it does have a lot of side effects in terms of tendinitis and just rupture of tendons. And so there's a black box warning on the fluoroquinolones for our patients. So we do use those as a very last resort for our orals. The ones that are going to inhibit protein synthesis are going to be usually static, but cidal in very large concentrations in some of the antibiotics. So blocking protein synthesis by not allowing the continuation of or proliferation of the bacteria is going to allow us to stop the bacteria from actually continuing to replicate, but it's not going to kill it off. So our tetracyclines and our macrolides are going to stop the bacteria from continuing to grow and continuing to cause more of an infection. But with our tetracyclines and macrolides, we need our immune system to really come in and clean out all of the bacteria that's sitting in there. And then last but not least is going to be our folic acid. So these are going to block the production of folic acid, which the bacteria is going to need to produce DNA. So animals are going to ingest folic acid. We get it from our diet, but our bacteria actually produces its own folic acid to produce DNA and RNA. So the sulfonamides and trimethoprim are going to block the bacteria from being able to produce the DNA and the RNA. So this is kind of like a quick overview in terms of how these antibiotics work. And we are going to get into the actual antibiotics in a second after we do polling question number 2. So what is the mechanism of action of our sulfa antibiotics like sulfonamide? Does it prevent folic acid synthesis? Does it inhibit cell wall synthesis? Does it inhibit protein synthesis? Or does it inhibit nucleic acid and DNA synthesis?
Okay, your polling question is open. Joe, are there any questions in the chat box?
There are not.
All right, let me know.
They are rolling in. Again, for those who need the polling question, if you look at your screen, at least on a computer, I'm not sure what it looks like on a phone. Over on the right-hand side, there's chat, there's polls. You can click on that polling, and it should open up to the question. All right, let's see here. Nicely rolling in. Looks like the trend is set, so let's display. And we have 46% going at folic acid synthesis, 19% going with B, 8% going with C, and 27% was your next runner-up. It inhibits nucleic acid and DNA synthesis. So 47% folic acid.
All right, you guys are doing great. You're awake. That's good. Okay. Cytostatic, we talked about. In terms of adverse effects, again, we talked about this. If they say they're allergic, make sure, it's an actual allergy. Um, just really quickly, in terms of antibiotic resistance, the reason I want to just talk about this really quickly is because we, as a healthcare community at large, have been overprescribing medication. The patients are not either following the instructions on how to take the antibiotics, or they are just discontinuing antibiotic use sooner than they're supposed to, all of which is going to lead to drug resistance. But one of the main things that actually, so there's a lot of talk in terms of, doctors overprescribing, patients not taking them properly. But the actual main thing that's causing antibiotic resistance is the animals that we eat, on the farm animals that are grown, being fed antibiotics in their feed to prevent them from getting sick, and that is driving antibiotic resistance. So yes, prescribing correctly, definitely important. We need to be very, very diligent. We need to educate our patients on how to take the antibiotics, when to discontinue, how long to take them for. But there's also this other part to it, with the antibiotics being put into animal feed, which is a much larger kind of causative effect for why we're seeing a lot of bacteria that are now able to resist, or live through the antibiotics that we're giving them, such as MRSA. And it's usually either a single chromosomal, just, a freak mutation that happens, but the bacteria are actually really, really smart. So it will have this one little kind of chromosomal mutation that makes itself resistant to a specific antibiotic, and then it will send that information on to its friends, through a little tiny plasmid, which is just a small little sequence of DNA. And the friends will kind of pick up the little plasmid, put it into their DNA, and then the whole group kind of becomes resistant to the antibiotic that you're trying to treat them with. So that's what's happening. One thing that I think we don't talk about nearly as much as we really, really should is the effect of antibiotics on oral contraceptive. Um, just on like the female anatomy in general. So oral antibiotics are going to increase your chance of developing a yeast infection, as well as prevent your birth control, whatever form of hormonal birth control that you're taking, from working. So if you are prescribing an oral antibiotic for a female of childbearing age, that is something that you need to bring up to them, that if they are using hormonal contraceptive, it doesn't matter if it's a pill or a ring or an injection or whatever type of contraceptive it is, if they're using a hormonal contraceptive, then the contraceptive is going to be much less efficacious during that period that they're taking the antibiotic, as well as for 1 week after they stop the antibiotic. And there's a lot of talk about which antibiotics actually, cause a is and which kind of don't. There's enzyme inducing antibiotics, non-enzyme inducing antibiotics, which is less, which is more. At the end of the day, one has a 7-fold increase in inducing or inhibiting the function of hormonal contraceptives, and the other one has a 13-fold increase in preventing hormonal contraceptive from working. So, 7-fold is still bad. It's less than 13, but it's still bad. So please, if you're going to be putting your patients on antibiotics, discuss the contraceptive component with them, which I have yet had a doctor do with me, actually, um, which I think is an important thing to discuss. All right, so let's see here. Ooh, another important thing that I don't think a lot of ODs are necessarily very aware of is that there is a large trend going back pretty much a decade now of decreasing the amount of days that we are prescribing oral antibiotics for our patients. So there have been a lot of studies. One of the main ones that is usually talked about is duration of antibiotic treatment in community-acquired pneumonia, that is showing for infections, including things like cellulitis, for infections that are not very severe infections. So, for your mild to moderate infections, doing a 3 to 5 day course of antibiotic therapy is just as efficacious as doing a 7 to 14 day course of therapy, and causes much less side effects and deals with the infection just as well. So, we don't necessarily have to overkill how long we're prescribing our medications for our patients. So we don't want to necessarily prescribe a 10-day course for a mild, hordeolum or something like that. When we talk about oral antibiotics, so we talked about anything that's kind of on the ocular surface, we're going to do much better with a topical. When should we start to think about oral antibiotics is when we think about things like a bacterial keratitis, cannuliculitis. Chalazion, some people will prescribe antibiotics for. It doesn't really make too much sense to me because there's no active infection going on there anymore, because it's a chalazion, no longer a hordeolum, but it is listed as one of the things that orals might be prescribed for. Chlamydia, definitely, dacryoadenitis, dacryocystitis. If you have any lacerations to the eyelid, you might want to do like a prophylactic, any type of trauma to the adnexa area. Any type of STD is going to require an oral and sometimes a topical as well. If we have any type of an infectious keratitis, corneal penetration, if we have an internal hordeolum, any type of Lyme disease, syphilis, things like that. And then we can use very low dose doxy for things such as ocular rosacea, for ocular surface disease. And then things like posterior uveitis, preseptal cellulitis, blowout fractures. So all of those are going to warrant a consideration of our oral antibiotics. If you have an infection of the eyelid of the adnexa, you're going to give them an oral antibiotic, but that does not in any way prevent or take the place of them still doing the warm compresses as well as the massage for them to kind of move all of the macrophages and all of the things that have infected that area, we need to get it warm and we need to do a massage to get it out of that area. So the oral antibiotic is either going to kill off whatever is in there, or it's going to stop it from replicating and need the immune system to come in. But you still must do the warm compresses. You must do the massage to actually improve the body's ability to clear out the things that have gathered around within that adnexa, or else you're going to delay your healing for a lot of your diseases. So let's talk about our penicillins and our cephalosporins. So these are beta-lactams. These are going to, our penicillins or amoxicillin specifically, these are going to be our very first choice for our soft tissue disease, especially if we're dealing with a moderate or severe soft tissue infection. Your amoxicillin is going to be your first choice, your first go-to, because it is going to fight against the cell wall. And again, remember, we don't have a cell wall, only they do. So it's going to kill them, not really cause a lot of toxicity to us. It's category B. Historically, it is safe to use in pregnant females. It's safe to use in children age 12 weeks and up, safe to use in lactation. So, and it really penetrates your soft tissue very well. So our amoxicillin is going to be our initial kind of number one go-to for your moderate to severe soft tissue disease. So that's, you know, our preceptals, for example, or our severe hordeoli that we talk about. So again, we talked about the fact that bacteria is very smart and is going to try to kind of counteract the antibiotics that we send in to kill it. So the bacteria has actually developed an enzyme, beta-lactamase and beta-penicillase, which actually go in and cut up that penicillin ring in the penicillin. And so we have started adding clavulanate into our amoxicillin to give us augmentin, right? So augmentin is going to be our amoxicillin plus clavulanate. And the clavulanate itself is going to have a little bit of an antibacterial property, but really the usefulness of this is going to prevent the bacteria from cutting up the penicillin and making the penicillin inefficacious. So if you're dealing with an adult patient, especially where you want to prescribe a penicillin to them, so amoxicillin, you have to add that clavulanate. So you can write out for amoxicillin, brand name, but if you're writing out for the generic, you have to make sure to add that clavulanate in for your prescription. The clavulanate is always going to be at a dose of 125 milligrams. That is never going to vary. So what is going to vary is your dosage of the actual amoxicillin if you're writing out an augmentin prescription. Important thing to note is some people will say, so for example, you might have an augmentin 250 dash 125, where you have 250 milligrams of amoxicillin and 125 milligrams of clavulanate. And people will say that I'm going to take 250 milligrams of augmentin instead of, say, for example, one 500 milligram tablet of augmentin. But we really can't do that with augmentin because the dosage in the 250 milligram tablet and the dosage in the 500 milligram tablet is not going to be the same. So we don't want to substitute the 250, or we don't want to substitute the 500 milligram tablet with 250. If your dosage is actually 500 milligrams, you want to make sure that the patient is getting and taking the 500 milligram tablet and not just taking, so say they might have leftover antibiotic at home from an infection they had previously and they still have some augmentin left over. You don't want them taking 250 milligram tablets because you're not going to be getting the same dosage of the medication. MRSA, we don't really deal with too much unless you're in more of like a healthcare setting, or you have a patient with with immune deficiency. Healthcare workers, athletes will be much more prone to getting things like MRSA. Um, Unfortunately, it is pretty much on the rise. So we were about 20, 30 years ago at about a 2% incidence of MRSA, and now we're up to about 40% um, in the United States. So that is when the uh, Staphylococcus aureus becomes resistant to methicillin, and the methicillin, which is one of our stronger penicillins, no longer will kill the bacteria. So if you do come across a infection that is not getting better, that is acting as if it's resistant to the drugs that you're putting it on, then your doxycycline and your Bactrim are going to be your go-tos for those MRSA suspected medications in terms of your oral arsenal. Your penicillins are not going to be effective against MRSA. So Augmentin is not going to be one of those that's going to be effective against MRSA. If we're thinking MRSA, we're going to go doxycycline or Bactrim. Let me see. So in terms of our dosaging for our penicillins and for our cephalosporins, for our adults, we usually want to do about 1 to 1.5 grams per day. So your dosaging is usually going to be about 500 2 to 3 times a day, or if it's a more severe infection, 875 2 to 3 times a day. Pediatric dose anywhere from 20 to 40 milligrams 3 times a day. So depending on what infection we're dealing with, and we'll go through some examples there. In terms of contraindications with our penicillin, so again, if they have a penicillin allergy, again, make sure it's an actual allergy. There is about 20% crossover allergy or sensitivity with cephalosporins, especially with our Keflex or first generation cephalosporins. So if they're actually allergic to penicillin, they might also be allergic to cephalosporin, or if they have, GI upset or sensitivity with penicillin, they will likely have it with a first generation cephalosporin like Keflex. And then our usual cautions like any type of GI disease, liver, kidney disease, any type of blood thinners, or methotrexate use for our arthritis and psoriasis patients. The Augmentin will actually increase the levels of methotrexate in the system. So that is one medication that we want to be cautious with. In terms of adverse effects, the patients might get GI upset, vomiting, diarrhea, nausea. For our kids, they might get a diaper rash in the area when they're taking it orally. And then for females, there might be some discharge or itching. So that's something normal as a side effect that they can go to the OB for if needed. And then there's the potassium form. So, depending on what your pharmacy is carrying, if they have a large dose of the potassium form that they're taking, that might cause hyperkalemia. And here they're going to get things like muscle cramps and limb tingling. So, that is kind of a sign that they're taking too much or a much higher dosage of the Augmentin than they really should be. And eventually this can cause arrhythmia. So we really want to make sure that they give us a call if they experience any of those symptoms. For our cephalosporins, again, very similar to our penicillins, they are also susceptible to beta-lactamase that the bacteria is going to produce, but to a much, much lesser degree. And so we don't have to add that clavulanate that we usually do to the amoxicillin to prevent it from being kind of broken down by the bacteria. And then this is another one that is not going to be effective against our MRSA or MRSA. So if you have a suspected MRSA infection, your Augmentin, your cephalosporins are not going to be your go-tos. Just, it's important to remember that. We have different generations of our cephalosporins. The first generations are going to fight your gram positives much, much more effectively than the third generation. So as we go down or I guess up in generation, we are in our first generation going to be fighting the gram positives much more. Our third generation, which is IV only, is going to be fighting our gram negatives much more. So we usually stick with our second generations, the Seclor, which has a good coverage, broad spectrum of both the gram positives and the gram negatives if we have a severe infection going on. And again, just like we had with the Augmentin, about 1 to 1.5 grams per day, split into usually 3-time-a-day dosages. So, for example, if we have like an internal hordeolum, right? So, a lot of you like to do a Keflex. So, for an internal hordeolum, 500 milligrams 2 times a day for about 7 days with your hot compresses, with your massages. Definitely don't forget that. Very, very important. Um, Keflex is actually going to be our usual go-to for things like a trauma or an orbital blowout fracture. So with that, we'll usually do something like a 500 3 times a day for 7 to 10 days to make sure that we don't get any kind of an infection going on in our um, sinuses. For our contraindications, again, crossover sensitivity with the penicillins, hemophilia, we want to have extreme caution in patients that have any type of warfarin or Coumadin use with our both penicillins and cephalosporins because it can induce hemophilia in those patients. And same thing, the hypersensitivity, the diarrhea, nausea, fatigue, yeast infections, all of those are potential side effects for our cephalosporins and for our penicillins. So let's do polling question 3. Greg?
Yep, it is open.
Yep. All right. So which of the following statements is false? Antibiotic misprescribing, improper antibiotic use, and antibiotic use in animal feed are among the top causes for increased antibiotic resistance in bacteria. A cidal medication kills the bacteria. A static medication kills the bacteria. Probiotic and alternate contraceptive use should be discussed when oral antibiotics are prescribed. Which one is false?
Also, a question came in
Mm-hmm.
considering, and this goes back to the first part of your question,
Mm-hmm.
your earlier talk about resistance.
Mm-hmm.
Considering resistance, how about antibacterial cleansers?
Antibacterial cleansers. You mean like wipes?
I think so, yeah.
So, you know, by putting antibacterials into things like soaps, into wipes and things like that, I don't think that has necessarily contributed too much at large to resistance, but it can definitely contribute to your own change in your normal flora. Right. So on your face, for example, if you're using a cleanser with an antimicrobial on your face or on your skin, it's going to really change your natural normal flora because it's going to kill off all the good stuff as well as the bad stuff. And then that is going to allow the bad bacteria to kind of come on and cause an infection. In terms of actually causing antibiotic resistance, it likely plays a role, but not, I don't think I've read that it has played as significant a role anywhere near as, for example, animal feed or improper use by the patients of the medications of the antibiotics.
We're good.
And I do want to just clarify when you're saying, when you're prescribing Augmentin, that's my go-to
Mm-hmm.
usually. Just checking for penicillin allergy. It penetrates well. It's hard to get
Yeah.
things,
Yeah.
I just want to clarify that to the audience when you're saying that you have to add it. It's there. Just make sure you're not using amoxicillin by itself. If you
Yeah.
type in, when I do my
The
electronic
generic.
health record, what I'm doing is I type in Augmentin and then I can click on the generic form of it. And then it will have the amoxicillin plus the clavulanic acid that's in it.
Mm-hmm.
which again is for the audience that's out there. It's really because there's all these bacteria are pus producing, especially in the eye, and amoxicillin will get that failure, go to that beta-lactam ring. So that's, you really want to have that clavulanic acid to help with the it has a higher affinity for it. It's more attracted to it. So the clavulanic acid kind of neutralizes that beta-lactamase, and then it helps it kill the bacteria. So I just want to let people know that
Yep.
it's there. You just have to kind of dig around for it. You don't really have to add it.
Yeah, yeah. I guess I guess I'm talking about when you write it out on paper, but we don't usually do that anymore. So yeah, on the EMR, it's gonna be added in there on its own. Yeah.
So
Uh,
the answer is we got 5% at A, 2% at B, 1% at D. So your winner is 92%. A static medication
all
kills
right.
the
Very
bacteria.
good. Good job, guys. Good job. All right, so let's move on to our sulfonamides. So usually, right, so usually our beta-lactams or penicillin cephalosporins, if you have an actual infection of the eyelid, of the adnexa, your penicillin cephalosporins are really going to get into that tissue, really going to hit it hard. Those are going to be our go-tos. But we do have patients that are allergic to our beta-lactams, right? And so we are then going to be considering our sulfonamides. We're going to consider the sulfonamides pretty much because they also hit the soft tissue really hard. They really penetrate the tissue very well. And so they're going to get the job done. And even though they do have some significant side effects and they're historically category C in terms of pregnancy and in pediatric use, we the side effects are not as for the efficacy that they have. The side effects are not as bad as some of the other oral medications that we have in our arsenal, and so those are going to be kind of like our backup medications if your patient really truly has an allergy to a penicillin or cephalosporin. The key here, so we've been talking about make sure the patient actually has a penicillin allergy. It could be a hypersensitivity. That's not the case with our sulfa meds. So if a patient says that they have a sulfa allergy, more likely than not, it is an actual true allergy, much more so, much more likely to be a true allergy than when we're talking about a penicillin allergy. So we have to be really careful here because some of the side effects of an allergy to a sulfa agent are very severe and lifelong, such as Stevens-Johnson syndrome, anaphylaxis, and toxic epidermal necrolysis. So this is stuff we don't want to be inducing in our patients. So when a sulfa patient tells you that they have a sulfa allergy, then you want to listen a little bit more closely. Safe to use in children beginning at 4 weeks, but historically category C in pregnancy because it might cause hyperbilirubemia in our pregnant patients. And then you will very rarely, if ever, see the two sulfonamides used separately. So we're usually going to see them used together in combination as Bactrim, and that is because individually, there's actually a much higher likelihood of bacterial resistance developing if you use the sulfonamides individually. So we will usually combine them together into Bactrim, and they work synergistically. So they work off of each other, and they work much better when they are in combo. So you're usually not going to prescribe them separately for your orals. They have a broad bacterial resistance. Um, so well, they have a broad bacterial resistance and sulfa allergy potential. So we do want to be a little bit more cautious with these sulfa medications. If you are going to be RXing a sulfa medication for more than 2 weeks, which is not done frequently, you want to make sure that you are providing the patient supplement oral for folic acid as well. So they're going to take 5 milligrams of folic acid every other day because then you can induce folate deficiency anemia in the patient if they're on a sulfa oral for a long period of time. But that's not usually going to be the case in the optometric setting, but it is an important thing to know just in case you are going to be prescribing it long term for your patients. So you have the single strength Bactrim. A lot of times, much more commonly, we're going to be prescribing the Septra or the Bactrim double strength. So that's going to be 160 milligrams of the trimethoprim and 800 milligrams of the sulfamethoxazole. And you will usually use that double strength if you're trying to get rid of soft tissue infection in the patients, such as a preseptal, for example. This is one that we want to inform them to really, so it usually says take with, a big glass of water or 8 fluoral ounces of water. Your sulfamides are ones that you really want to make sure that the patient is getting plenty of fluid, because it can form kidney stones if they don't hydrate well, your sulfa medication. So this is one where you really need to be hydrating as you're taking the medication, and really avoiding alcohol use with your sulfa medications, because it can cause a fast heart rate. It can cause tingling of your skin, severe nausea, severe vomiting. So we really want to avoid alcohol, drink plenty of water with your sulfa medications. And then again, remember that this is one of those where you can consider if a MRSA infection is considered or on the differential. In terms of who do we not prescribe this to, anyone with a folate deficiency, anyone with an allergy. There is a cross sensitivity with other sulfa-based medications such as Celebrex, CAIs, thiazide diuretics. If they have a sensitivity or an allergy to any of those, they likely have an allergy to Bactrim, so we don't want to be prescribing that as the antibiotic of choice. If they have megaloblastic anemia, if they have sickle cell disease, then we want to keep away from the Bactrim. And we already talked about things like arrhythmia, jaundice, Stevens-Johnson syndrome. So just be careful with educating these patients. And then from our end, our sulfa medications, any sulfa medication can cause choroidal effusion in our patients, as well as on its own standalone transient myopia. So from our end, if your patient is on an oral sulfa medication, those are some of the ocular side effects that we could be having. Our macrolides, azithromycin or Z-Pak, Zithromax, Z-Max. So these are wonderful medications because they have a very long duration of action. And so you'll take the medication for 5 days, but it will actually keep working as an and its antimicrobial properties for about 7 to 8 days. So you're giving them a much shorter amount of time for them to actually take the medication, but it's working for a full week. The reason this is not the go-to, the macrolides or the Z-Pak is not the go-to for our moderate and severe preseptals, for example, or hordeoli, is because we don't get enough of the medication getting to the target site, so getting into the eyelid. So we might not get an actual therapeutic dose good enough to kill off all of the bacteria. So if we have mild to moderate hordeolum, for example, or a really early preseptal, I definitely, for a mild to moderate hordeolum, definitely my go-to is going to be the azithromycin or a Z-Pak, because it's very easy. They get the little package and everything is kind of spelled out for them. You take 2 pills the first day, and then you take 1 pill each for 4 days, and it actually works for 7 days. So it's wonderful. And it's kind of, dummy proof in a way for our patients. But if you really have a severe soft tissue disease, this is not an antibiotic you want to reach for, because you're not going to get, it's not going to penetrate good enough into the soft tissue, and you're not going to get a good therapeutic dose to really kill off the bacteria. And so you need to go with your augmentin, with your cephalosporin, with your sulfa medication for those more severe infections. Let's see here. And then chlamydia is, so if we have inclusion conjunctivitis, then just a 1 gram single dose, just one time. It's powder that's diluted in water, 1 gram, drink it, and you're good to go. So this is what's usually used for our inclusion conjunctivitis patients. If we are talking about things like ocular rosacea, ocular surface disease, posterior blepharitis, chlamydia, so doxycycline has been making very big waves, low dose doxycycline, longer term for anything like ocular surface disease, ocular rosacea. But there was actually a study done looking at azithromycin 200 milligrams per day for 5 days versus doxycycline 200 milligrams a day for 30 days. So much higher dose than you normally would for doxy in terms of what we would give for something like an ocular surface disease, as well as for a month versus azithromycin 200 milligrams for 5 days. And the verdict came back that both of these improved meibomian gland symptoms, but the azithromycin actually had a better effect for the signs, overall clinical response, and had better duration of treatment for meibomian gland dysfunction. So, less medication for a less period of time, doing just as good of a job for meibomian gland dysfunction, both signs and symptoms. I would say that, that is a good response.
Tamara, actually,
Mm-hmm.
there's another similar low dosing that we have been using in our
Mm-hmm.
practice.
Mm-hmm.
It's azithromycin 1 gram
Mm-hmm.
once a week for 3 weeks.
For ocular surface or
Hmm.
ocular rosacea.
Rosacea
Interesting.
and meibomian
Rosacea.
glands. It
Interesting.
also
One
compares to.
gram once a week for 3 weeks, which would compare to doing 200 for 5 days.
Mhm. or
Okay.
or it compares to the doxy.
Okay. Is that something you guys are just doing on your own, or is it
No, that
published
no, that was published in a study, and we've been doing that, and I found it to be pretty
to
effective.
be effective? Okay. Have you tried the just the 5 day course of the 200? Is like
No, I went I
no.
went I went right from doxy to the azithromycin 6 pills.
Okay. Okay. All right. Interesting. Yeah, I've been doing the Z pack and it's been working really good, but there are some of those patients that need that kind of extra something. So maybe that's, I'll try that next time. I have one of those more chronic type of resistant patients. All right. So for our azithromycins, if your patient is on a statin drug, we want to be careful because it can increase the risk of myopathy. If they are on digoxin or medication for epilepsy, Coumadin, of course. If they have myasthenia gravis, the azithromycin can actually exacerbate the symptoms of their myasthenia, so you want to be cautious with that. In terms of our adverse effects, so GI upset, diarrhea, definitely. So we're going to be taking it with food, headaches, dizziness, fatigue. But one that patients get really nervous about is this can actually cause things like palpitation and arrhythmias because it is going to cause ventricular tachycardia potentially. So anyone with any type of cardiac history or any kind of questionable cardiac problems, we don't want to be using the azithromycin on. So again, make sure you know the history of your patients. Our tetracyclines, so specifically our doxy. Um, the important thing here is, so all of the other ones can cause GI upset. Don't want to take it on an empty stomach. Take it with food. Doesn't really matter what food you take it with. Just make sure it's not on an empty stomach so you don't get that GI upset and the diarrhea. For your tetracycline, so for your doxy, diet is going to be extremely important to talk about. So just like with sulfa, we want to make sure that they are drinking a lot of water so that they don't get those kidney stones. For your doxycycline, we need to talk about food because if they take within 2 hours before or 2 hours after, if they take any type of multivitamin, any type of calcium and acid, laxative, iron supplements. Those things are all going to decrease the efficacy of the either antibiotic, or if we're using for anti-inflammatory properties, it's going to decrease the amount of absorption of the doxycycline into the system. So we want to, for this medication, really try to, tell them if they can kind of stand it and they don't get GI upset, avoid food as much as we can. But if they do get that GI upset, you really need to give them a list of things to avoid, such as any type of dairy, and acids, magnesium, multivitamins, iron supplements, calcium supplements, laxatives, 2 hours before and 2 hours after taking the dose of doxy, because it's not going to allow the antibiotic to absorb into the system. All right. So in terms of using doxy as a antibiotic, again, this is one of those that we can use with MRSA. But we have kind of a lot of restrictions in terms of, dietary restrictions. We have a lot better medication that we can use, such as the augmentins, such as the cephalosporin, such as the Bactrim. So we can definitely use the doxycycline for its antibiotic properties if need be, but it is now more being used for its ocular surface disease, meibomianitis, sebaceous blepharitis, ocular rosacea, recurrent corneal erosion type of situations, because it has at lower doses, instead of working as an antibiotic to kill off microorganisms, it has an anti-inflammatory property, and it also has an anti-collagenase property. And so it works really, really well for those ocular surface disease, anti-inflammatory, anti-seborrheic type of situations.
And Tamara,
Mhm.
that's probably why when we go back to one of your earlier slides, or referencing one of your earlier slides,
Mhm.
the question is why would chalazion be a condition that an antibiotic would be prescribed for?
Yeah,
I think the doxycycline is the
is an
only,
example.
it's
Yeah.
really the only example, because
Yeah.
I will do that very frequently.
So for kind of recalcitrant, or like a
Yeah.
large
Mhm.
chalazion, yeah, I'll put
Yeah.
them on a low dose doxy as well, with a lot of heat and a lot of massaging. The massage, I feel like if they don't do the massage, the antibiotic really doesn't do too much. You really need to get them to physically kind of manipulate the things in there to get the system to take everything out.
Yeah, we
I
got a
don't know,
couple.
have you? Mhm.
So we just had a couple quick questions came in.
Yep.
And here's a really good common one. Doxyhydrate or monohydrate, which is better?
Uh, I don't, I honestly, I go with the hyclate usually. But I know others that go with the other one, and it can go back and forth. I don't really, I'll be honest, I don't really have an amazingly good answer
Mhm.
for that. I don't know if you do.
No,
Yeah,
I
so
go ahead,
yeah, so
Greg.
it doesn't matter whether it's hyclate or hemihydrate. It's the delivery system of it. I tell people that it's like vodka. You can have vodka in tomato juice. You can have vodka with cranberry juice. You can have vodka with ginger beer. It's just the delivery. And what happens with this and why it gets confusing is there's no rhyme or reason, is that where you can't get them. I don't want to say back order, but yeah, you just can't get. They're not available. And so one time the hyclate is like $1,000, and the hemihyclate is. It doesn't really matter. Is the answer. One is a capsule, one is a tablet. So if you're trying to cut them in half, taking 50 down to 25 to maybe do some low dose meibomian gland, that might be a little difficult to do the capsule with that. But that's a long answer. The short answer, it doesn't matter, hemihyclate or hydrate.
Yeah.
Yeah, and another question came in: is Eliquis also a concerning blood thinner like Coumadin for you?
Eliquis?
Yes.
Uh, No, I actually haven't come across Eliquis. It's an anticoagulant, right?
Mm-hmm. Yeah.
But it doesn't, I don't think it has the same efficacy or as much of a blood thinning property as Coumadin
So a
from what
little
I
bit less
recall.
concerning.
Yeah, a little bit less
Mhm.
concerning. I would still, if they're working with a hematologist,
Mhm.
um, or if they're on a blood thinner in general, I would still discuss with their hematologist before prescribing an antibiotic, because if they're on a blood thinner, there's a reason for it, and you don't want to mess with that. So you definitely want to check in with the hematologist. At the bare minimum, let them know that you're putting them
Mhm.
on the antibiotic, but I don't believe it has as much of an interaction as Coumadin or warfarin.
Yeah,
And
Mike, let me give a little quick answer to
Mhm.
that. It's because
Mhm.
it's a short period. Like if you're treating a sty, or if you're treating something that's short dose, the dacryocystitis, whatever you're going to use for, I'm going to say Eliquis, it's safe to use the antibiotic that's out there short term. If you're going to do some long term stuff, like you're going to treat meibomian gland dysfunction, get into some, where they're on it for maybe months. Again, just notify them of that. But the short term, by the time you get them treated and get them off and get everyone notified, everything's going to be back to normal. So it's not like
Yeah.
the Coumadin or warfarin days.
Yeah.
yeah, we're all caught up with the questions, but we need to we're down to our
Finish
last
up.
minute.
Yep.
If you want to wrap
Okay.
that up for us.
Yep. Yep. So the only other kind of thing that was left is the fluoroquinolones, which really and honestly in optometric care we're not going to touch because they have such severe side effects. So just to finish up with the doxy, if you I one key thing is if we're using the doxy low dose for something like an inflammation such as ocular rosacea, it's important for you to taper them off the medication. So maybe you'll start off with 50 milligrams twice a day for about 6 weeks, and then cut them down to 25 milligrams twice a day for another 6 weeks, and then discontinue, like you would for a steroid, for example, because we're treating more of an inflammatory condition with ocular rosacea. Whereas if we're just dealing with meibomian gland dysfunction, for example, then we don't need to do the tapering. We can just put them on 50 milligrams 2 times a day, 4 to 6 weeks, and then just take them off, and we'll be done. And I think we covered pretty much everything. I have in your slides case examples for those of you that want to go through the case by case, and what would you do here and how would you do there. But I hope this was helpful in terms of kind of breaking down the different options and where you would use what, and what things to consider when and how. So let me know if you have any questions.
No, I think that was a great overview. Great, that'll be great help for people going into clinic tomorrow or whenever their next time is in clinic. I will make a final comment about fluoroquinolones. Is that again, I agree they have a lot of side effects that have happened over the last few years. But if you have someone that's allergic to penicillin, you have someone that's allergic to macrolides, you have someone that's allergic to cephalosporins, you have someone that's allergic to sulfa, that would be a go-to again. But remember, they do have those side effects of the prolonged QT elongation. They do have the issues
Yep.
with the tendon ruptures and then a
Tendons.
few
Yep.
other things that's out there. So just remember that it is used maybe as last line of defense when everyone's allergic. So.
Yeah, definitely. I mean, it's a great antibiotic, but yeah, more of a last resort. And if you need to use it, you need to use it. It's the levaquin loopy is it causes a lot of psychotic episodes as well. So levaquin specifically can cause delusions for the patients as well.
And the dose would be Cipro, 500 milligrams twice a day. Usually try and stay away from the Levaquin. So with
Yeah.
that said, now you can see on their screen that the little red dot has popped up. And if you want to start that survey, please go right ahead and do that survey. Then it will save you from 8 minutes from now receiving that email. Joe, I'm on the last slide here of questions and thank you. Are there any further questions or comments?
No, we're all good. You're
Okay,
just getting
so
your virtual round of applause because people appreciated the talk tonight and the efforts and education you brought. So thank you so much.
Thank you. Thank you.
Yep, perfect. Yeah, I agree. It was a great discussion. So for all the states out there that need that, it was great CE. When topicals just don't cut it. Oral antibiotics and eye care. This was a synchronous course. This will end the CE. Thank you very much for doing this for us.